There we go.
Yep. This right? You guys good? Excellent. Let me just move these people on the side here. And I'm not sure how to move that. We'll just move that out of the way. All right. So the presentations regarding methadone in the context of pregnancy and postpartum. So Lisa already went over the objectives, so I'll continue to skip ahead. So just a general statement that opioid use disorder is not uncommonly seen among deliveries here. So just under one in every 100 deliveries is affected by opioid use disorder nationwide, which I thought was a pretty sobering fact. So methadone itself is a full mu opioid receptor agonist. It's been used for more than 4 decades for opioid use disorder. Its dispensing is limited to mostly licensed opioid treatment programs, or also known as methadone clinics. And apologies, it looks like this overlaps here, but the primary goal of methadone is to reduce cravings and withdrawal symptoms. I will say historically, there were actually three different goals of methadone that kind of occurred at different doses. At a certain dose, it would control withdrawal symptoms. Above that dose, to a certain extent, it would control cravings. And then historically with heroin, it would actually be a blocking agent, where if you saturated the mu opioid receptors with methadone, you wouldn't feel the effects if one were to administer heroin. With the age of fentanyl, I actually no longer tell patients that just because I think the potency is so great that you can still feel the effects. So for this purposes, I say withdrawal and cravings. So it does not produce euphoria in opioid dependent individuals because the binding is slower and longer lasting than that of heroin fentanyl. And there's a strong evidence base for methadone that dates back decades at this point that reduces illicit opioid use and risk of overdose. We've got Cochrane review studies that show fewer opioid positive drug tests and increased rates of retention and treatment when patients are medicated with methadone. So a little bit on the methadone dosing strategy. When patients come into my clinic, they're generally walk-ins. We do get some from the hospital, but if a patient were to come into the methadone clinic and not be started on the medication in the hospital, I'd sit them down. We do an intake that takes about half an hour, and then they'd be assessed for, what should we start them on? How severe is their use disorder? And I'd say 95% of patients and all patients with fentanyl use disorder started at 30 milligrams, which is a federal requirement as the maximum amount of fentanyl that can be given on day one. This data here is from SAMHSA TIP 63, which is a few years old and frankly outdated in the age of fentanyl use. They say the minimum therapeutic dose is 60 to 120. I say for people using a gram of fentanyl, the dose is going to be over 100 and sometimes significantly higher than that. Important to note, still the case, the risk of overdose is known to be the highest in the first 2 weeks of treatment. So I'm always counseling patients to use tester shots and, as always, to never use alone. And important to note here that for patients coming into treatment, they have to know that to find that therapeutic dose where they're not experiencing withdrawal and their cravings are reduced can take weeks to even months of time to achieve that. So it does require a lot of patience and persistence and commitment on the part of patients to get to the clinic every day while that's happening. Let's see. So here we go. In terms of MOUD, buprenorphine versus methadone, there was a large-scale observational study, some pooled analysis of randomized controlled trials that found that retention on buprenorphine is actually inferior to retention on methadone. Now, this data is a little bit older. Things are constantly in flux. We know buprenorphine is becoming more accessible. But as of right now, my understanding is that methadone remains the gold standard of treatment for opioid use disorder. So methadone in pregnancy, methadone maintenance has been repeatedly demonstrated over 45 years now to reduce neonatal morbidity and mortality. An old consensus panel in 2005 from the Center for Substance Abuse Treatment labeled methadone as the standard of care during pregnancy. Of course, this was right at the advent of buprenorphine. I couldn't find more recent consensus panels on that. But some recommendations coming out of that panel where they recommended increasing the methadone dose as necessary to keep the mother out of opiate withdrawal. And the panel knows of no compelling evidence supporting reduced maternal methadone dosages to avoid neonatal abstinence syndrome. as I kind of described before, there's no real consensus on the best dosing strategy during pregnancy, but we'll get into that in a little bit. So I'm sure you're all well aware of the physiologic changes that occur during pregnancy. Methadone metabolism is primarily through the CYP3A4 enzyme. So that consistently increases during all stages of pregnancy. So the half-life of methadone, which is normally 24 to 48 hours, is effectively reduced to about 12 hours over the course of pregnancy due to that increase in metabolism. Also, characterized by significant water retention and fat storage early in pregnancy, which is later decreased later in pregnancy. All this put together means that there's a change in the distribution of methadone. And the bottom line is that pregnant patients frequently require higher doses of methadone throughout the pregnancy. So split dosing is it's an option that exists at methadone clinics. The vast majority of patients are provided once daily dosing. There's a couple indications, the biggest one being pregnancy for split dosing, where patients that are daily dosing at the clinic, they dose in the morning at the dispensary, and then they receive a take-home bottle of medication with a dose in it that they can take later in the day. The next day, they bring the bottle back in, their dose, they get a new bottle, and so on and so forth. So with split dosing, one of the primary goals of methadone is to prevent stressful effects of drug withdrawal on the fetus. Also, ultrasound evidence with daily dosing has noticed abnormally increased motor activity before the dose, as well as significant depression after the dose when it's just dosed once a day. And then these findings were actually normalized on twice daily dosing regimens. So put another way, single daily doses of regimens, or when the patient's forced to remain on a low dose regimen, can expose the fetus to daily episodes of an intrauterine abstinence syndrome associated with increased fetal adrenergic excess and potential hypoxia. So I think the main takeaway here is that women should be offered a split dose treatment protocol during their pregnancy. This is kind of some pretty compelling evidence looking at multi-dose or split dosing regimens among patients with opioid use disorder, and then the general population women delivering. And you can see that there's really comparable outcomes between the two populations in terms of gestational age, birth weight, preterm, cesarean section, and breastfeeding. Postpartum methadone dosing. So during the postpartum period, we slowly transition the patient back to single day dosing. Say they were on a 160 milligram split. Every week we go up 10 milligrams on their morning dose, down 10 milligrams on their afternoon dose, and do that for a couple weeks until it's all kind of consolidated into one dose. It is important to note that with the subsequent physiologic changes post-pregnancy, patients are typically able to return to their pre-pregnancy dosages. So it's important to monitor for sedation, as a dose that worked for them during pregnancy may no longer be appropriate after delivery. So I wanted to bring forth an article that was just published a couple months ago that I thought was really relevant to the conversation today, with Suarez, which compared effects of methadone and buprenorphine treatment on pregnancy outcomes, specifically with the baby. And it did note a pretty significant difference in that 69% of the infants exposed to methadone experienced neonatal abstinence syndrome, while only 52% of those exposed to buprenorphine experienced NAS, which is significantly different. This is the table from that chart. It's a little busy, but among neonatal abstinence syndromes, whether the patients are exposed early in pregnancy or later in pregnancy, the outcomes are generally saying that treatment with buprenorphine has slightly better outcomes than methadone, with a lot of those outcomes being significant. So I'm sure you guys are well aware of this study, but it's just important to note. Now, there was a response to this study by an obstetrician and addiction medicine specialist. Said in the methadone system, pregnant women are routinely forced to take methadone the wrong way as a single dose, in spite of a uniquely rapid metabolism that necessitates divided doses. Single doses cause daily cycles of intoxication and withdrawal in the mother and fetus, as well as cardiac and motoric abnormalities in the fetus, these changes will certainly adversely affect outcomes. So he's basically saying that if we did control for the variable of split dosing, we might not be seeing those same variations between buprenorphine and methadone among outcomes. So let's see, I can't read my slide here. So when is methadone treatment most appropriate? So before initiating treatment with any MOED, the following should really be considered: patient's preference, patient's previous experience, and access to maintenance therapy, which in the instance of methadone can play a really large role in what the patient inevitably begins treatment with. So what medication do I choose? There's currently no evidence to predict which patient will do best with which medication. And in the study I was looking at, the main guide is patient preference. They did study stepped care in which patients were started on treatment on buprenorphine and then transferred promptly to methadone if they weren't responding. And this demonstrated to be just as effective as initiating treatment with methadone to start. So how I go about it in my practice, especially if I have a young patient coming in that's naive to treatment, it is easier to access buprenorphine as opposed to methadone. So if they're open to either possibility and they're able to tolerate the induction and on, I generally steer them in the direction of buprenorphine. The vast majority of patients that turn to methadone have undergone trials, usually multiple trials of Suboxone, which is proven to be ineffective, which leads them to methadone treatment. And then individuals not responding to buprenorphine who were transferred to methadone had significantly improved outcomes, as I was just describing. So when Suboxone, when Subutex doesn't work, sometimes methadone, well, it's really the only other option, but methadone not having a ceiling can really you can achieve a therapeutic dose. It can take time, but inevitably, whether it's at 100 or 180 or 200, we even have patients here at 300 milligrams, which, gets me to stop for a bit and, catch my breath when they ask for a dose increase. Either way, you can achieve a therapeutic dose on methadone. So I want to make sure that everyone had access to this slide, which shows the forget it's either 12 or 13 opioid treatment programs in the state of Maine with the concurrent phone numbers. Really what should be happening, a lot of these clinics are at times closed to referrals. Ideally, if a patient is pregnant that you're having and lives in one of these areas for clinics that are closed to referrals, they should be prioritizing them and making exceptions. I'm not sure if that's, required, but if need be, getting your state SOTA involved and describing the situation, I would advocate. We, of course, would take a pregnant patient at here at the formerly Discovery House. So basically just kind of a summary slide here, methadone, the impact on pregnancy. Obviously, one of the challenges in the methadone clinic is the daily dosing strategy when patients first enter treatment here. We have patients here coming to South Portland from as far away as Lewiston because the clinic up there is closed to referrals, people from Booth Bay that are driving well over an hour to get here. But they do it because methadone works and they know it works and there's no other option for them. So it can be burdensome, and that's something that you should definitely be counseling your patients on. And along with that, the first month of treatment particularly can be challenging while the patient approaches a therapeutic dose. Also, it's a moving target, especially in pregnancy. What once worked for them, I had a patient recently that was stable on 150 and then she became pregnant. And then unfortunately, her physiologic changes, she relapsed, and now we're kind of working again to re-achieve a therapeutic dose. But also worth noting that doses do need to be reduced post-delivery to prevent that oversedation. And split dosing is common in the third trimester. I will say if a patient comes in even in, at 10 weeks gestation and says, they're feeling the effects, they feel like it's wearing off, I give them the benefit of the doubt and I give them a split dose. My goal is to make the patient comfortable so the baby can be comfortable. So not to say that's everyone's practice, but especially in the third trimester, those physiologic changes necessitate a second dose during the day. So another question, when should you reach out? I would have the patient sign a release of information at the first visit. I make a point of doing this. I know Elaine and I have been in touch and contact regarding a couple mutual patients. I always like hearing from providers. It's always great to have them reach out to me. Reasons for it: if there's continued use during pregnancy, we monitor with monthly drug screens here. We tend to have a pretty good pulse on whether the patient's continuing to use, but it's whether there's over sedation concerns. We typically see them in the morning, so if they're in withdrawal, we don't see them later in the day. So if you have an appointment later in the afternoon, you're seeing patients at a different time following their administration. That can be helpful if you do see something that would be helpful for us to know. Changes in pregnancy status, care transitions. I also note that I do try to meet with patients every 4 to 6 weeks, every pregnant patient, just to check in, see how things are going, making sure that they have adequate OB follow-up, and make sure they're kind of understanding the situation, what's going to happen in the hospital setting.
MaineMOM.
What? Oh, moms.
Yeah.
Okay.
And those are my citations. So I don't know how long that lasted. I think I was doing pretty good on time. So let me stop share here, and I'll open it up to any questions if people